Thank you, Jean-Michel, and thank you for giving me the opportunity to give this lecture that is going to be the very last one and the closing one for this HIV clinical forum in Europe. These are my disclosures. And this is a 59-year-old male. He was a previous intravenous drug user, now on a methadone maintenance program. He has had an HIV infection diagnosed for more than 30 years ago, and he has had in the past irregular treatment adherence. Comorbidities, the most important one is a chronic psychiatric disease, it's schizophrenia, with difficult control in the past in this patient, and he has a bad metabolic profile with hypertension, lipoatrophy, and the whole metabolic syndrome. He had, like all intravenous drug users, he had a chronic hepatitis C infection that was cured with DAIs in the past, no reinfections, and his nadir CD4 cell count was 45 cells, with a zenith of viral load of more than 800,000 copies. At diagnosis, he had pneumocystis pneumonia, but no more comorbidities, so no more co-infections in the subsequent future. Regarding antiretroviral treatment, he started with ACT plus 3TC. He received a boosted PI, saquinavir and preenavir. He received boosted darunavir and first-generation NRTIs like efavirenz and nevirapine. He has documented biological failures with dual NRTIs, with boosted PIs, including a failure with boosted ritonavir-boosted darunavir, with an integrase inhibitor, raltegravir, and he has never been exposed to dolutegravir or T20. He refused. Currently, he's receiving twice-daily ritonavir-boosted darunavir, twice-daily raltegravir, and TDF-3TC. And the physician wonders if a new drug with a new mechanism of action should be in place in this case. He has 124 cells, and his viral load is 3,160 copies. These are the compiled genotypes. Remember always, as Anna was explaining before, to compile all the genotypes. You can see the protease mutations, a long list. 3 of them are in red. There's a reason for that. They are in the score of darunavir, so they are directly impacting darunavir, not in the same weight, all 3. We're going to see that in a minute. These are the RT mutations in the left against NRTIs and in the right against NRTIs, with giving an important reduction of activity to all these drugs. And in the integrase, we have 4 mutations. He has a non-R5 tropism. And if you look at the history of this patient, he has been walking through a very dangerous journey in the past. He started with mono or dual NRTI treatment. He failed to first-generation NRTIs or unboosted PIs, which were drugs with a very low barrier against resistance. And he received sequential functional monotherapy with new drugs that were coming up and were not completing suppressive regimens when they were available. So he had biological failures to this low barrier to resistance regimen. And remember that nowadays we only see resistance selection with regimens with low barrier to resistance, including boosted elbaitegravir, raltegravir, or rilpivirine. And obviously the absence of a complete co-formulated regimen that facilitated selective non-adherence. This is not the fault of our patients. This is the fault of not having better treatments in the past. So we cannot claim a reason for the patient on all this. As you can see, this has been a sequence along the years, and there's always a common background regarding adherence issues. So usually in the form of severe social problems, psychiatric disease, or toxic addictions for alcohol or drugs. These cases are always complicated cases, so they are never easy cases. And we have a second very different profile, which are children infected at birth, mother-to-children transmission, that have accumulated resistance along the childhood. And when they come to our office in the adolescence or in the early adulthood, they come with multi-drug resistance. And it's very important as well the possibility of a transmitted drug resistance on all this. When you got all this information, you can phone Jonathan Shapiro, or you can go to the Stanford website, and you got an estimation of the possibilities you can still have with these drugs. In the left-hand side, we got protease inhibitors in black, major mutations or important accessory mutations. There are 3 mutations impacting the darunavir, and the weight is not the same. You can see 20 points to 50 baleen. It's a very important mutation for the darunavir. And we have 2 additional mutations with a low score, but the final score is 30, so intermediate resistance. Remember that between 30 and 60, we are in the starting of intermediate resistance. In the left-hand side, we've got integrase inhibitors. The weight for dolutegravir is the same, 30 points, so again, intermediate resistance. These are the 2 drugs with the measure, the most important barrier to resistance, the most important background regimen in these salvage individuals. So we learn for this that these drugs have a compromise. They have not the full activity, they have not the full barrier against resistance, but they still have activities, so it's important to put them in the salvage regimen. Regarding NRTIs and NRTIs, it's surprising that tenofovir still has 15 points, so low level of resistance. Tenofovir is actually a drug or a compound with a high resistance barrier. And then we got the NRTIs, etravirine has 30 points, so again, intermediate resistance. Realize that doravirine has 20 points. Actually, in real life, we don't see an important difference in the score of resistance between doravirine and etravirine. So the estimation of the activity we have now, it's intermediate activity or resistance to darunavir, intermediate resistance to dolutegravir and to etravirine, and still active tenofovir. The patient refuses T20, so these are data coming from the interpretation of the mutations, but do we have any clinical data, any additional clinical data? And this is very important, and this is an analysis coming from the POWER and the DUET studies where we registered the indication of darunavir in salvage. And you can see in black, 39% was the overall response rate below 50 copies at that time, so the better response we could get was 39%, and in red, 12% is the rate of response in the comparator arm. In green, you have the stratification of the treatment response if darunavir had no mutation at all, 1 mutation, 2 mutations, 3 or 4 mutations in his own score. Obviously, every mutation does not weigh the same, but overall, you can see that there's a steady decrease of the activity of the drug with every mutation. So it's not something that is maintained until you lose your activity, but with every mutation that is in the score, you lose a clinical response. This is not in vitro data, this is clinical response. And this is our patient, has 3 mutations against darunavir. And remember that he has 15 protease mutations, and in the clinical trials, with 3 mutations against darunavir, you can see that they had a median of 14 protease mutations. So it's very nice to see the patient had 15 mutations in the line of those studies. What about dolutegravir? In the Viking studies, the researchers did a very thorough study to identify surrogate markers of treatment response. And the only one they identified was having the Q148 mutation. This is a Q mutations for the attachment of dolutegravir in the intosome, in the receptor of the integrase. And when you have this mutation, the union is unstable, so the drug is not attached in an efficient way. So the treatment response overall was 69% at 24 weeks. In only 8 years, we went from 39 to 69 because all the drugs from previous trials were incorporated in the Viking trials. They could receive etravirine, dolutegravir, darunavir, so 69%. But when they stratified no having Q184 or having Q184 plus 1 or 2 mutations, the treatment response rate was 79, 58, 24%. So if you have Q148 plus 2 additional mutations, your possibilities of reaching a response with dolutegravir are very, very limited. Our patient does not have the Q148 mutations. What do the drug regulatory agencies say? Should we use a drug with a new mechanism of action in this patient, in this scenario, or not? They are not too optimistic. They say literally, you can use fostemsavir or evolizumab when it is otherwise not possible to construct a suppressive antiretroviral treatment. This is a problem because this can help the physician go too late to these salvage regimens in these patients. Let's see, actually they copied the inclusion criteria of the clinical trials. They literally copied the inclusion criteria. What do the guidelines say? The EX, the European guidelines, say when a 2 or 3 drugs active regimen cannot be constructed, you can add a new drug with a new mechanism of action to have a suppressive regimen. Sorry, and the US guidelines, the DHHS guidelines say in a similar way, consider using an antiretroviral with a new mechanism of action. Actually, in my opinion, this is probably wrong, and the real statement should be, in this situation, you should strongly consider including a new drug with a new mechanism of action. Why am I saying this? First of all, because of mortality. This is the mortality we saw in the BRIGHT study. I am reviewing the BRIGHT study because we had 400 participants in that study. It's a huge study with a lot of information. So mortality, we are not used to see mortality in clinical trials. We never see mortality in initial treatment or in switch studies. And when we see mortality, it's always related to HIV or to the treatment. It's due to an accident, an homicide, or something different. In the BRIGHT, it was 4% at 1 year and at 2 years in the randomized cohort, so people with 1 or 2 active drugs, but it was 14% at 1 year in people with no active drugs. So clearly, these people were reaching too late to this life-saving treatment. It was 14%. And the majority of this mortality was AIDS-related mortality. In other words, it was preventable mortality. So too late for these people to get this drug. And obviously, mortality was strongly associated with the CD4 cell count. It was 15% below 20 cells in the baseline, 6% 20 to 200 cells, 2% beyond 200 cells. 200 cells is like a life-saving threshold. So we need regimens to take out these patients from this life-threatening scenario. Okay, we have identified 3 factors associated with treatment response in salvage in all the studies with iberalizumab, with lenacapavir, or with fostemsavir, which are the CD4 cell count, the HIV viral load, and the number of active drugs. You can see that in people with a high viral load or a very low CD4 cell count, below 20 cells, the rates of treatment response are 35%. But in the other side, if you have a low viral load or a high CD4 cell count, you can reach a treatment response close to 70%, even in these people with only 1 or 2 drugs, active drugs. And regarding the number of active agents, estimating the activity of these agents is not easy at all, so they had to run different scores, but finally, in the optimized sensitivity score, new, so a new drug to the patient, they could very nicely stratify the treatment response regarding the number of active drugs. And you are lucky, and you have 2 or more than 2 active drugs, you can reach an 80% of treatment efficacy. That's very important. Even in the Capella study that was elegantly commented by by Dan, you can see that with only 36 participants, you can stratify the treatment response regarding the CD4 cell count or the HIV viral load, even with this low number of participants. So remember, if you have someone failing with multi-drug resistance with a low CD4 cell count or a high viral load, that's a patient with a high risk of not responding to treatment. You have to very carefully estimate the residual activity of all the drugs. And finally, it's not only regarding the viral load suppression, it's also about the CD4 recovery. All these drugs obviously have associated with the biological suppression a very nice CD4 recovery, but particularly it looks like fostemsavir has something differential. In blue, in the randomized cohort, at 2 years there was a median CD4 recovery of 200 cells. That's the median. So half of the participants recover more than 200 cells at 2 years. In green, the non-randomized cohort, despite low rates of biological efficacy and having no active agents at that time, they had a 119 CD4 cells, median CD4 cell recovery at 2 years. And this happened in patients with any CD4 cell count at baseline. Even those who recovered the most at 2 years were those with the lowest CD4 cell count at baseline. So those with less than 20 cells, with a higher risk of death, as we saw before, they had the highest CD4 recovery at 2 years with 240 cells. That's a median CD4 cell recovery. Okay, and going back to our patient, he was started on twice daily dolutegravir, twice daily ritonavir boosted darunavir, etravirine, tough FTC, as Jonathan has taught us along the years, well before the Nadia study, and for stem cell. A close follow-up with psychology was performed that's as important as the antiretroviral treatment, with specific treatment directed at facilitating the control of the psychiatric disease. And this is the evolution. In the first row, you have the CD4 cell count recovery. At 12 months, he has 285 CD4 cells. And you can see the decline of viral load. It was undetectable at 6 and 12 months, and undetectable and target not detected at 1 year. So that's all. Thank you very much.